to introduce our two co-presenters. First is Jeff Miller. He's the Executive Vice President and co-founder of Navvis and Company, which is now Navvis and Healthways because they've recently been acquired by Healthways, which is a provider of well-being improvement solutions. Jeff has over 25 years of experience as a senior health advisor. He's worked with a broad range of healthcare organizations throughout the country with a strong emphasis on business and medical staff development, planning for hospitals and health systems. Jeff has overseen and conducted numerous engagements in the areas of strategic and business planning, service line planning, program and service feasibility, and medical staff development. He has pioneered and developed decision support tools and resources that support strategy and business development for Navvis Healthway clients. Joining him as well is Dr. Peter DeWan, who is a co-founder of Activate Networks and responsible for the management and strategy of Activate Networks' scientific methodology. Over the last few years, he's developed new network-informed approaches to targeting populations for behavior change, particularly with physician networks. He's completed his doctorate in sociology with Professor Christakis and developed substantial expertise in statistical modeling and social network analytics. He holds a BA from Columbia University and a PhD in sociology from Harvard University. And they're going to talk today about the wonderful things they've done with physician referral leakage analysis. Jeff?
Thanks, Darren. I guess my first question, I just ask, how many people are actually from a health system, hospital in the market? So quite a few, good. We're going to talk a lot about the topics that are in some of the categories that are very obvious to the folks that are in the trenches in the hospitals, but I think provide a little bit of a background to you all for setting the stage of the analysis that we're now doing with Activate Networks. You do, okay. Some of you that were just in with Bruce did a very good job of introducing kind of the concept. I think you're all familiar with, obviously, the network analysis. Again, though, the strategies we're going to do. Before I jump into this, I just wanted to take just a quick second to elaborate on Darren's point about Navvis and Healthways. So what we've been doing at Navvis for 25 years is building integrated delivery systems. So we've been doing all the strategic planning, but really about half our work has been transactional. So we have brought together physicians, hospitals, and all sorts of arrangements and all sorts of governing structures and so on and so forth. So a lot of work with that. We were acquired last year by Healthways, who's got 25 years of experience in wellness and population health and well-being, all those pieces. And the trend we're going to talk about today is this movement, which I'll say in a moment, of the health systems are being pushed and some embracing, but we're being moved into the side of healthcare that they're going to be responsible for populations, going to be responsible for the risk populations. We just heard Bruce talk about ACOs and how all that works. So this is this world that health systems, so we've been in hospitals for years, have been acquiring the parts of the system, so assembling these networks, assembling physicians, assembling the pieces. But we're really shifting, and the driver today is we're shifting from a pay-per-volume world to a pay-per-value world. So this is depicting a healthcare administrator that's struggling with when to hurdle that ditch that's there and possibly be stuck in both worlds for quite some time. So what we're talking about there is the economics that drive healthcare delivery today is volume. We're paid every time we cut somebody, every time we zap somebody, every time we take a picture of somebody, or put medicine into them. That's how we get paid. And that's not where we're trying to go to as healthcare reform's coming. But the difficulty is that's how the money comes into a hospital. So how can we hurdle this? How can we straddle this world in today's world and live in both for quite some time? So we're seeing the pace of healthcare reform. It's not overnight. We can't just turn the switch here. This is years of being paid one way, and only a little bit of our business today is in this new world. And quite frankly, even with reform coming, we're not sure that it'll come at the pace it'll come. I mean, the Supreme Court's looking at this even today as to maybe undo some portions of what is now law. So it's very difficult for us to do that. So what we have when we try to look at we heard today, accountable care organizations, what's on the opposite side, or the value side of this ditch, there's lots of great ideas. So hospitals sit around all day and we have these great ideas how we can exist in this future model in theory. But so we're skeptical because we're not sure whether these are going to work, whether reform's going to happen, or even whether it's the right things to do. And when we analyze these things, we discover that the economics are so tight, these aren't home runs that say, let's do a bundle payment, let's do an ACO because we're going to make a ton of money in that. And that's hard to Again, healthcare, think about healthcare, just the money decision, but these are expensive things to do and very difficult to implement. And most of these are all saying, do more for less money. So all these things we have to do as providers of healthcare services is do more things for less money and even a tighter and tighter margin that we have. So we're full of ideas. Again, readmissions avoidance. In today's world, an admission, whether it's a readmission or not, we get paid. Hospital gets paid. So we don't have a problem from an economic standpoint with patients coming back over and over and over again. However, we all know as consumers, it's the last thing we want. We want better health care. We want it to reduce the number of readmissions. If I go into the hospital, I don't want to go back a month later because something went wrong. I want to stay home and be well. So all these are difficult to do. Go on. So a little bit more on this today and tomorrow. So we believe that the formation of a high-performing network, which we talk about a seamless connected network of hospitals, ambulatory centers, and physicians, is the answer. So how do you create this high-performing network? So how does a high-performing network enable success today without walking down a dead end of tomorrow? So what is it? So I think it's easy to think about these ACOs and where it's going. So we're here today to talk to you about activate networks, what can be done today, real analysis that works into the world of pay for volume today, but positions you into the future. So again, talking about that though is kind of today, just a little more setup of this is hospitals today try to create easy access for us and then easy navigation of the system. We could all question whether health systems are doing that well, but that is their goal. How do we get you in? How do we give you access? Then how do we navigate you through the system? In the future though, when we're responsible for populations, it's one step even in front of that. It's how do you get access to information? That's websites, knowledge for the people that aren't sick. And then once you are sick, how do you enter the system and easily navigate? Today's systems are really built around taking care of the sick, not taking care of populations, and it's moving to that. So today, the main topic we're talking about today is this referral. We call it leakage. It's interesting because in a hospital, everyone knows right what that is. But in a broader setting, we talk about a leakage analysis. It's probably not the right words. But so today, what we do for hospitals are focused on today when they talk about referral management systems, and that's really what we're talking about. How do we manage the referrals? We're really generating referrals to create demand and to generate volume. So, and again, as cold as this sounds, but why do we do cancer screenings is to get to the cancer surgery. The more screenings we do, the more surgeries we get. The earlier we do them, well, sure, it's healthier for people to detect cancer sooner, but the fact of the matter is a hospital gets paid when they do the surgery. So that's driving the business today. And so the more access we do, it's all about feeding or creating demand and then generating volume. In the future, referral management is going to be about eliminating gaps in care. So we just heard some analysis around ACO. What's the ideal network to properly manage care? Well, you can't have gaps in coverage. It has to be comprehensive coverage. You can't have stuff that's leaking out of your system because you have no control over it. So the future is going to be about managing the gaps in coverage and promoting well-being. So we want to get to the point where we do screenings to promote well-being, not screenings to feed our surgery. We will have surgery, and we'll need to do that effectively and efficiently, but that's not the purpose of the networks. So this is where we're heading. And the last point on this is really the high volume equates to high revenue and high margins today. In the future, high volume is going to equate to high cost and low margin. So on the previous slide, we talked about bundled payments. So CMS, Medicare, is all kinds of test pilots right now, and they're trying to bundle even more things together. One of the bundles being looked at is 3 days before a hospital stay, 30, 60 days after, all the care, one price. So if you go home and you wind up as a Medicare recipient going to another doctor on your own, the hospital, if they're at risk for that bundle, they're going to be writing a check for all that other stuff that happens outside their system. Even if it's not, so it goes to a competing hospital, they're paying the bill. So that's the need to change as volume becomes a cost center for those hospitals. So that's in essence the setup. And so what I want to do is set the questions up. There's what we've been working with Activate Networks for the last 6 months, trying to create analysis today that hospitals can embrace and that focuses on those economic drivers of today's world. But really, we're gonna talk about where it's ultimately going, and not just the leakage analysis. But the point is, you've got to analyze your network. You have to understand the performance of your network. And to achieve high-performing network, first requires a key assessment and answer these questions. So the first thing we talk about is what are the sources of leakage? So when inside our network, How does a patient flow through and then get referred out of our control? So where does that happen? Why does it happen? And how much of it that happens? So where does it go? So does it wind up at another hospital? Does it wind up at a physician-owned surgery center? Where does that leakage happen and go to? Ultimately, what's the economic value of that? Because it's very important in today's world for selling this type of analysis, and the reason we're doing it and why we're trying to pull the network together, you have to justify these investments in this effort with the economics. So if we can determine that there's $1 million of business leaking out of our system, it's very easy to rally around what we want to do about that. So maybe we need to go talk to those doctors, find out why it's leaking. Maybe we need to acquire them. Maybe we need to buy that asset that's sitting out there that's getting those referrals. If there's a top-notch a cardiovascular surgeon that everyone wants to go to, let's get them aligned with our network. Let's add them into our network in some way, shape, or form to, again, control that. So we want to put the dollars next to that, and we're going to talk today about how we do all these things with the data that we do that. Then really where it's going. So this is kind of the easy, what I call the low-hanging fruit. This is the world today where we're chasing volume, chasing dollars, and it's easy to see why, from a business standpoint, we do this. But where it really needs to go in the future is start to say, well, what parts of our network are performing at the top decile in terms of cost? Was someone in the last meeting even asked about this? Patient satisfaction, quality. So how can we find the sub-network? So one of our clients today is in Dallas. They've got 17 hospitals, 4,700 physicians, and the Dallas market has 20,000. So this is their size of the analysis we're looking at. We're anticipating there's probably going to be 30 or 4 sub-networks of physicians that support that, all around those hospitals and pieces. So how do you get your arms around all of that and look at it as the people in charge of this entire health system? Again, 4,700 physicians that they have active relationships with today, and that's only 25% of the physicians in the market. So big, complicated networks. And how do we introduce these things? So how do we look at the sub-parts of that? So if we discover one aspect of the network has the best performance and cost or quality, how do we then take what's learned from that network and disseminate it into the rest of the networks? How do we find the influencers? So that's the next point. Who's influencing? What's the difference between those two sub-networks, and who are the influencing physicians? And how do we learn from them, possibly apply it to the other networks, connect broader networks, the sub-networks, and so on? And then again, how do you disseminate? There's a lot of talk today about how do you then communicate into these networks and activate the changes of behaviors you want. So again, I consider this a low-hanging fruit. We're really into it right now with Activate Networks, doing a lot of this, and this is the future stuff. That's all really what we're hearing today. What I've been excited about, what we've heard today, is this is the change in behavior that goes on with the network analysis really is the future. So I'm going to turn it over to Pete, who's going to answer some of these questions, and then we'll take questions from you all about how we do this.
So I'm going to go through this kind of fast, but feel free to stick your hand up if you feel like I'm jumping through it. I actually do the science, so sometimes I jump over things that are not clear. But we're going to run out of time, so I'm going to try and run through some of these pictures. A lot of nice pictures I have here. The first thing is, you may have seen this from other talks, but the first thing is that we're able to look at the patient flow between physicians using claims data. This is a very simple idea. We watch a patient take a claim with one physician. We watch them take a claim with another physician. We can see how patients flow through the system. And you start to get something that you'll see here starts to look like a picture of a network. From this, when we start to talk about leakage, it's the patient flow that's the most important thing. What we're concerned about is how patients move through this, which physicians we want them to be going to, where we want them to go in this. There's another step that you can take with these, though, and you'll also see this in other talks that you see around here. We can take all these flow networks and we can apply algorithms to figure out which one of those represent relationships that if you went and asked that physician, who do you respect, who do you ask for advice to, who do you send to, we can figure out which ones of those relationships are the ones that are important. So a claims data set is a physician is going to have a relationship with 100, 500 physicians. If you're just looking at where the patient flow is, we apply algorithms there to take out the few of those relationships that are actually meaningful information sharing relationships with these physicians. And from that, that's where we can start to do things like not just look at how the patients are flowing through the system, but think about which physicians are influential in that network. Additionally, we can take a network, once we've drawn this, what you see on the right here, a network of physicians, and we can break that down into communities. We apply, again, an algorithm in here, and we find clusters of physicians who are closely related to each other across a wide variety of things we've looked at, including treatment, prescribing, HEDIS measures. We'll see that they cluster in these communities, that physicians form communities that move together, that treat together. They have relationships with physicians who have similar properties to them. All right, now we're going to get in some kind of pretty pictures that we've been making. And again, as Jeff was saying, we're right on the cutting edge of this. We've done a bunch on leakage, and as we go through, I'll go through some few things that we're just starting to work on now, and we still have to develop some of the work. What we're looking at here is a map of the yellow dots represent primary care physicians. We're looking at the primary care physicians and all the relationships they have with each other. Again, what I'm finding is not just patient flow here, but the relationships that the physicians have. If you went to ask them, what we're detecting from claims data, about 80% accurate. That is what you'd find if you actually went and asked that physician. We've tested that with survey data. The green arrows are arrows going out to specialists at various institutions. So the first thing that we can start to do is look at this either on this social network map or on a geographic map and say, what does the environment look like? Here's what your environment of primary care physician looks like. Here's how it's going out to all the other facilities in the area. Here's where I am. Here's a competitor. And this gives you an overall view of this to start talking about what's your relationship with the other facilities in the market. Now, looking at this a little bit more closely, we can start to see that physicians have particular practice patterns. On the left, we see a physician that has a loyal in. In other words, that's a primary care physician that's reliably referring their specialty patients to your facility. That's one thing that's obviously somebody that is of interest to you. Maybe you want to reward them, use them as a model, find out what physician they have a trusted relationship with at your institution. A lot of the physicians, however, we see are more like the middle picture. Patients are coming in, they're going in a lot of different directions. Now, there's actually a really key, very simple, and it's going to seem kind of obvious inference from this, is that if a physician has a trusted relationship with another physician, they're going to be sending all of their patients in a pretty consistent direction. They're going to come in, they're going to say, I want you to go see this cardiologist that I trust, and we're going to see that path in the claims data. However, some physicians, you see the patients going out in all different directions. And so what we can infer there is that that physician it's not likely physician choice that's leading to that leakage. And so from the perspective of the hospital, what you want to say there is that's not going to be as easy a situation to change as the one where we can tell that it's a physician that has a trusted relationship. That's somebody that you can go talk to and maybe change that situation. Patient choice, obviously, a much, much more difficult problem to approach. And then additionally, you're going to see people that are loyal out. This is going to give you a sign of how to deal with this physician. Again, sorry, I got to go through this stuff fast. The next level, and where social network analytics starts to really provide a lot of value here, is that we see that, in this case, we'll see primary care physicians forming, as I've said, these communities. Within these communities, you'll see that physicians will act similarly to each other. And what we see is that they're all working as a group. They're referring in the same kind of directions. They together have trusted relationships where they're sending their patients in a particular direction. And what that tells you is that you're looking at a community of 15 physicians that are all doing the same thing. You should not be treating them as individuals. You should be looking at who's influential in that group of 15. How can I change a few of those relationships to get this whole community to start to say, now we have a trusted relationship with somebody in our facility, rather than this trusted relationship that's causing leakage for us. So the kind of overall idea here is that we're taking essentially two axes here. We're saying how much of what's happening here is due to the physician's choice. We want to focus on changing it where we can talk to the physician, where we can change them, and how influential is that physician on other physicians' practice. So our ideal candidate, if we want to look at leakage, is somebody who it's their choice. They're the one that are directing the patients where they're going, and they have a lot of other people whose behavior they're influencing. And so we can then take a list of that, prioritize that by the value to your facility, and figure out where you should focus your resources on leakage. Now we're going to go through a few more kind of cutting-edge things. The first thing that, as I've already mentioned here, when we look at these physician communities, we see a wide variety of behaviors. In fact, almost everything that I've looked at so far has clustered together in these communities. The one exception to that was somebody asked me to look at glucose strips. Did not work. Apparently physicians don't care about glucose strips, so that didn't cluster. Anything that physicians do care about, though, as far as I've seen yet across a wide variety of things, they cluster together in these communities, they have similar treatment patterns, and they influence each other's behavior. So what we'll do when we look at a wide network of physicians is we'll find low-performing communities and high-performing communities, whether that's cost, whether that's quality, treatment patterns. And one of the things that we might want to do there is start to change the way that the relationships work. And this may be some restructuring. This may be simply going to them and recommending that you start to have this, changing the way your departments are organized, these kind of things, so that you can start to hopefully bring the lower performing communities into contact with the high performing communities and start to have influence pass that behavior along through the network. So the next level of this, something that we've done a lot of so far, is targeting using networks. What we're seeing here is now a physician network. All the blue dots are physicians, the green dots are as well. You can see that the first we look at this and we say, let's pick the green dots to start whatever we're trying to say. So maybe we're trying to change a behavior in there, we're trying to put a new treatment practice, a new quality measure this, and we're going to pick the people that are in these central locations. You can see that that physician is obviously going to be a much more valuable person than that physician. They have a bunch of strong relationships that they're going to be able to spread out into a cluster. So we start by that, and as we go through this, we'll move through here and slowly push out from the centers. And eventually, we will end up being able to spread a behavior through a network. And this is substantially superior to looking at that without the network, because in this case, you can find all the places in the network where you need to do it. You can find the most influential people to start. And once you get a foothold, you can work out from there to continue to spread the behavior. And then finally, for those of you who already saw Bruce Landon's talks, I'm just going to refer to this really quickly. One of the things that we've seen that Bruce Landon was talking about this morning was the accountable care organizations. And the fact is that we can look at, again, we have this community detection, we can look at a network, we can find these clusters of connected physicians. What this helps us do is find areas where patients are more likely to stay within the system, which manages risk better for an accountable care organization. If you pick randomly, as you see in that other network, what you're going to actually have, those are patient flow connections that you're seeing there. Patients are going to be leaving that accountable care organization constantly. There's going to be trusted relationships that you're going to have to go try and change. There's going to be all these factors that are going to work against you being able to have continuity of care within your accountable care organization. If you work within a network-defined organization, what you're going to get is physicians who already have trusted relationships with each other, and the patients are going to flow along the paths that they already want to. You're not going to have to be fighting uphill all the time to maintain this.
No, thanks. I guess a couple things, and I'll wrap up with this, is that, back to the customer in Dallas, it's the use of resources. So we've discovered that you can actually reduce care if you send a nurse out to spend time with every doctor. Well, that's impossible to do that economically. So the strategy has to be, where do we focus those resources? So how do you roll out and talk to the right doctors at the right time? So just kind of in conclusion, we'll take questions. So we believe we're on this continuum here. First of all, assess your network. So find out whether it's ready for ACO, do all the analysis we talked about. Today we can live and really maximize this type of analysis to drive value today, and gathering the volume that you want that still is economically viable. And then in the future, it's certainly going to be critical for when we manage risk of populations. How do we make sure we have the right networks to control all those patients and be accountable for their care? So, questions? Yes?
You talked a couple of times about how influential doctors can help move the network activity. How do you define influential doctors?
Well, I'll start with say, if again, what we're using is physicians that, first of all, we're identifying physicians that have relationships with one another. So back to, and I'll let Pete talk about, but those clusters, those are doctors that appear to have relationships with significant numbers of physicians in their sub-community. So the influencer is that they have common patients, they're driving referrals, they have strong performance, and they do have a tight network. But again, I'll let Pete kind of answer that too.
At the simplest level, it's who has the most and strongest relationships, and who's in the center to pass messages back out through that. Additionally, you can look at how the patient flow goes, and you can actually see a treatment going through a patient history. You can see where a physician, in particular network physician, is going to make a decision that's going to then pass out through the rest of that patient's treatment. And again, when we see something spreading, a new behavior like a new prescribing behavior, we've looked at also exercise programs that are being recommended by the physician. We'll see that physicians in particular network locations are more likely to start them. When they do, it passes along their relationships outwards. Now, there's one thing about this that people often mix up a little bit in terms of the difference between influence and prestige. Influence, we're talking about when we're looking at this in these cases, we're talking about people that are doing things day to day, and the physicians around them are seeing that, learning from that. It's passing in the kind of discussions that you have in the hall every day throughout work. There's also prestigious physicians who you're going to find who do publications, who may not even practice very much, and that's actually in some ways a different question. Those prestigious and influential often overlap, but they're not quite exactly the same thing.
So is an influential physician someone that sees with our patients? I would think it's volume related.
It's related to volume, but not the same thing. So it depends on, if you look at a practice, let's keep it within a practice, it's often the most influential physician is not the person who's seeing the most patients. There's going to be people that are younger doctors, newer to the practice, who are going to actually be seeing the highest volume. But if you look at the network structure of that, you'll find that there's going to be a director, somebody that's in the center of that from a network perspective, that we'll find is influential. Yes?
On the influential physician, these networks maps that you've been creating, are you using commercial claims and Medicare claims together? Or are you making maps of like Medicare referrals where you might have different influencers on Medicare services or patient, they might have a bigger volume of Medicare versus commercial? How do you compare those things?
We have done some of that. They're surprisingly not as different as you would expect, with the exception of, obviously, there's some physicians that you lose with either data set. You don't get pediatricians or OB, and if you look at a Medicare data set, and you're gonna miss a certain amount of geriatric care and stuff like that in a commercial data set. Although we do get a certain amount of Medicare. The problem with a Medicare data set is that usually you can't get detailed enough information to do the analysis that you want for commercial purposes. So on our academic side, we do a whole lot of work with Medicare so that we can learn and do some comparison there. But what we're actually able to produce out commercially, we mostly can't use very detailed Medicare data. But what you'll find is that, again, they're very close. You get a really good thing, really good overlap between what those networks look like. And the difference is that some physicians who treat almost all Medicare patients, you might not recognize that their influence on that when you're looking at just commercial data. So there is a little bit of weakness there, but it's surprisingly less than you would expect.
I think there's both a scientific way that we're looking at it, and the fact that if all my patients go to one cardiologist, we believe that doctor is influencing his patients. If all his patients go to 10 cardiologists, we believe the patients are coming in and say, no, I want to go to my guy. So there's some of that. But furthermore, what we do on top of this is we load a lot of other data points. So if we've got satisfaction data around our physicians, so again, for the group in Texas, we've not only have commercial data that we've bought that tells us about the 20,000 physicians in the market and all these touches, we then can load real productive data from, we know how many admissions they've had, we know how many tests they've had, we know how much revenue they've generated, we've done a patient satisfaction study on them. All those pieces can be laid on top of the network, and then you can look at those performance and say, is there clusters around our highest satisfied networks? And that's where we clearly see that this influencing network of physicians has the highest satisfaction performance or the lowest cost or whatever it might be. So it's kind of those two combination things. Well, I would say this. I think what we're using the analysis for is to target those physicians and then and to fill out the network. So clearly the identification of networks and clusters to go after. I think the other measures we're talking about is there are incentive programs to improve satisfaction, all those things. We've not done anything in terms, a lot of hospitals have an incentive piece that it's part of being a good citizen and the physician. So in theory, we have not done this yet, but in theory you could start to apply, we want you to be an influential physician, and the more influential, we would rank that in maybe some bonus towards a good citizen. But I'm not aware of anyone that's using any formula that comes from this analysis to actually plug into their comp model. But that's probably where it would fit.
We've talked about it, but that's obviously kind of the final frontier when somebody's willing to make that step.
I think ultimately these models, though, an ACO will provide incentive to the physicians to perform. And so indirectly, by keeping it all in a tight network, you will have incentives that will trickle to the physicians because you don't have the leakage, you don't have the cost of going all over the place. So that's kind of why there's so many people coming together and saying, let's go after an ACO, even if whether it's ever economically viable or not. We actually believe that the Medicare ACOs are not going to be what makes hospitals money, but we believe when that ACO concept moves into the commercial business, that's where there's economics to actually go after it. So a lot of hospitals are learning on the Medicare world, and we're being somewhat forced into it because that's what reform is doing, but the real answer will be to create these high-performing networks that can do Medicare and go after the commercial business. Then you can go to a payer and say, let's reduce costs together and share that, and there's enough in it to do it. You know, we are doing another project in Jacksonville, and part of it's a Medicare bundle payment, and we just literally discovered that probably about 50% of the patients aren't even in the data because they register with Medicare in their home in Boston or wherever they might be, but they spend 6 months a year in Florida, and so it's very difficult to deal with that phenomenon. It's happening. So, you know, I think there's lots of opportunities to do that kind of sub-look is how do we just cater a product offering to just them or something, but no, I'm not familiar with that yet. But it's an issue with the data, that's for sure. Other questions? Good, thank you. Thanks, Pete.
Thank you.